a short talk here on cataract surgery in the glaucoma patient. Both cataracts and glaucoma are most typically diseases of the elderly, and it's therefore very common that we are faced with cataracts and glaucoma in the same patient. Either a patient who's going to surgery because of uncontrolled glaucoma who also has a cataract, or a patient who has symptomatic cataract but is also on multiple medications for glaucoma. Cataracts can also occasionally cause glaucoma in the case of phacomorphic glaucoma or phacolytic glaucoma. In eyes that are quite small, after iridotomy, some patients still have a very, very crowded angle, and in those patients, lensectomy can be quite helpful. And remember, too, that glaucoma surgery, trabeculectomy, can cause cataract formation. So the two are intimately woven together. The options are basically three. One can do cataract surgery alone, and then later, if needed, do a trabeculectomy. One can do trabeculectomy alone and later do cataract surgery, or one can do combined procedures. Cataract surgery alone is, over the last decade or so, becoming more and more common because with modern cataract surgery, the intraocular pressure typically will drop, whereas in the extracapsular cataract days, the pressure would more likely go up after cataract surgery. This effect is most commonly seen in eyes with narrower angles, and the degree of pressure drop is proportional to the height of intraocular pressure at the time of cataract surgery. In the ocular hypertension treatment study, randomized controlled trial that we'll talk about separately, but they dealt with the effect of cataract surgery on intraocular pressure. These are ocular hypertensive patients, not glaucoma patients, but it's such an important study, I think it's useful to look at this. They had 63 eyes who underwent phacoemulsification, and they had a significant drop in intraocular pressure from a mean of 23.9 to a mean of 19.8 millimeters of mercury. So a drop of 4.1 millimeters of mercury. Mean drop of about 16.5%. And importantly, this pressure remained lower than preoperative pressure for the 36 months of follow-up. So a lot of times now, based on this study and other studies that have shown a drop in intraocular pressure from cataract surgery alone, we will often just do cataract surgery in patients who have mild glaucoma who are not maximally medicated, and sometimes this will bring the pressure under better control by itself. Patients can also have trabeculectomy alone and then later have cataract surgery. Trabeculectomy alone probably has a higher success rate than a combined cataract trabeculectomy. However, if the patient has a significant cataract, then we would need to go back later and take the cataract out, and that subsequent surgery can slow the prior trabeculectomy or even cause it to fail. So I rarely do this personally because if there's a significant cataract. I do it sometimes if the pressure is in the 40s or 50s and I just want to get in and finish the surgery and get out because I feel like it's dangerous to extend the operation. But I have had quite a bit of success in these patients doing well with the combined procedure, and it's nice to get by with only one surgery. And so that brings us to combined cataract surgery with trabeculectomy. For eyes in which a marked degree of intraocular pressure lowering is required, eyes on multiple medications, eyes that have poor intraocular pressure control at the time of surgery, severe glaucoma damage, or the need for a very low intraocular pressure. So this is my preferred choice if there's a significant cataract in a patient requiring trabeculectomy, or if a patient undergoing cataract surgery is on several medications or has severe glaucoma. So we can potentially get by with one surgery. If the trabeculectomy part fails, then we could go back later and do a trabeculectomy. But there is the possibility, I think a pretty significant possibility, that these patients can get by on a single surgery. But this attitude varies from surgeon to surgeon. Cataract surgery can be combined with tube-shunt surgery, and the indications are similar to combined cataract surgery and trabeculectomy. But these are eyes that are poor candidates for trabeculectomy. They've either had multiple failed surgeries before, or a scleral buckling procedure, or something else that makes them a poor trabeculectomy candidate. In these situations, I would typically use a valved tube shunt, like an Ahmed tube shunt, because the Barvelt or non-valve tube shunts don't work for 6 or 8 weeks, and if there's viscoelastic and other things around, the intraocular pressure could be very poorly controlled for a long period of time. There's a tremendous amount of interest now in minimally invasive glaucoma surgeries, and there are data that show that they can provide an additional degree of pressure lowering when combined with phacoemulsification beyond that is provided by the phacoemulsification itself. Endoscopic cyclophotocoagulation, canal shunts such as the iStent and trabectome, and there are a variety of these surgeries now under development. And we'll talk about those more in the session on other glaucoma surgeries. Again, these are subjects of intense interest. They do lower pressure more than cataract surgery alone, and I think the debate revolves around whether the modest increase in pressure drop when compared to cataract surgery alone is worth the increased cost. And again, this is a subject of substantial debate. I think large randomized trials are needed to show the cost-benefit ratio of these minimally invasive surgeries. But this development is very exciting, and I think we'll learn more as time goes on here. So the key points: cataract and glaucoma frequently coexist. Modern phacoemulsification alone effectively lowers the intraocular pressure. Trabeculectomy or tube shunt can be employed concurrently or sequentially with cataract surgery, and the indications for phacoemulsification and minimally invasive procedures are in development.